Welcome, everyone, to our regular noon rounds. Today we have Tom Smith joining us. He is from our Perry Sound Community Paramedicine program. He is a graduate of Sheridan College and the CTS program. He is a AEMCA certified paramedic in Ontario and is also certified in aeromedical theory. He was also featured in episode 7 of the Community Paramedicine podcast for leadership in innovation and point of care technology. And he's currently serving as our superintendent of the program. In this role, he oversees the Parry Sound District Community Paramedicine program, a comprehensive rural model delivering in-home assessment, diagnostics and treatment through advanced clinical training, virtual care, and collaborative community-based partnerships. Welcome, Tom.
Awesome. Thanks, Kathy. Okay, so I just dive right in.
Please do.
Okay, well, thanks for joining today. What we're going to talk about is the Community Paramedicine program here in the district of Parry Sound. The whole point of this presentation is just enhancing community-based access. I'm going to do kind of a high-level overview of the entire program and what community paramedicine does, but I'll really kind of try and focus in on integrating virtual care and point of care assessments in community. Okay. So first off, a little disclosure. I do work for the West Prairie Sound Health Center. I am not, I don't have anything else to declare. I'm confirming there is no financial or in-kind support for this session. So some of the learning objectives, like I mentioned earlier, are right care, right place. So we're going to be talking about Ontario home and community-based care through integrated pathways, virtual care, and remote monitoring. Provider directed in-home extension. So again, this is going to be kind of around our medical directives and how we can integrate with diagnostics such as point of care and virtual care. Two of the main pieces of equipment that we use for this point of care is actually point of care ultrasound and the epoch blood analysis. So we'll also touch on that. And we'll go over some practical access use cases of situations that we've run into and some referral opportunities of when it is appropriate to be referring to community paramedicine. And throughout the whole thing, one of the main themes of the presentation is we talk a lot about what can be safely assessed, treated, monitored, or escalated in the home setting because safety is obviously always first and foremost. So as you can tell, I've had some fun with AI when it came to generating some of the images for my presentation. And actually, you'll see some patient images, and just none of them are real. They're actually all everything uh, pretty well in this presentation as far as graphics have been generated by AI. So this image right here is we hear a lot in community on the 911 side when we run into shortages of ambulances and code black situations. And again, code black is a situation where a 911 call comes in and there's a delay to response because we do not have any ambulances available. So I just kind of came up with this bit of an analogy. So we're always hearing people say we need more ambulances. So in this situation, we need more fire trucks. Sometimes the solution is not a more emergency response, it's the right response. So this image just kind of illustrates a fire department climbing a ladder to get a cat out of a tree while there's a burning house down the street. So when a fire truck is sent to every cat in a tree problem, it is not available when the house fire comes in. That's very similar in EMS terms. Every time we have a low acuity episodic event and we send a 911 ambulance, that ambulance is now no longer available for true emergencies when they do come in. So that's kind of where community paramedicine comes in. Community paramedicine is the person with the ladder. We're skilled, appropriate, lower acuity response that keeps fire trucks or ambulances available for true emergencies. Before we continue, I just want to kind of go over the area that us as a paramedic service, the area, the geography that we cover. It's a very large rural geography. We're over 9,000 square kilometers. To cover this region, we have seven paramedic bases. Our total paramedic staff is 102. Now that also includes casual and part-time staff, so that's not full-time FTE. In 2025, our annual call volume was 10,219 ambulance utilizations. It also includes transfers. What we've seen is a 22% 911 call volume increase since 2021. We transport primarily to three destinations: the West Prairie Sound Health Center, North Bay Regional Health Center, and Huntsville District Memorial Hospital. So why does all this matter? Every transport decision that we make is critical. So again, like I said earlier, weather, offload delay, time to return to a base, all those factor into unit utilization. If we're responding to a low acuity call in a remote area, that ambulance can be out of service for several hours, leaving a gap in coverage area. So CP as community paramedicine increases access to assessment and treatment while helping preserve 911 capacity for higher acuity calls. So that's really, really critical when we're in a geography like the Parry Sound District. And here's another kind of just AI image, but it kind of highlights what we're running into frontline with distance challenges the clinical pathway. So, for many of our patients that we see that just come in is not realistic. Our patients, they face all kinds of barriers to accessing care. First off, clinical frailty. A lot of our patients have mobility issues. We have transportation barriers. The Parry Sound District has no public transit. We have limited taxis. We do not have Uber. It's very, very hard for people if they don't own a vehicle to get from one place to another, especially when it's things like going in to see your primary care provider or going into the lab to get blood draws. Even follow-ups can be very, very challenging. Uh, Caregiver constraints. This is a new one that we're actually seeing quite a spike in. Now, this is where we have a lot of seniors caring for their spouses who have either frailty or cognitive impairment. And a lot of the time, when these patients should be going to the hospital or even to see their doctor, they're choosing not to go because they can't get respite to actually watch their loved ones. So a lot of the times on the 911 side, when we're bringing these patients into the hospital, we're actually bringing two patients in because their spouses can't be left by themselves. The other one that we run into is actually cognitive and memory concerns. So again, patients may have appointments that are booked with their primary care provider or follow-up or OT, or they need to go to the lab to get uh, labs done. But because of the memory cognition issues, they simply forget. So appointments get missed, labs never get completed. And again, that leads to declining health. So low acuity escalation points are fairly predictable from our standpoint. Many 911 to ED episodes begin as an access problem, not sudden emergencies. And we see this through the statistics that we're pulling from our 911 crews. So high yield, avoidable, and this is from some research through other emergency departments and some stats online, and other 911 services. So high yield avoidable or potentially avoidable escalations. We see a lot of urinary symptoms, UTI, catheter issues, retention, dehydration, pneumonias, acute respiratory infections, CHF, edema, fluid overload, a lot of falls, skin tears, COPD, bronchitis exacerbations, cellulitis, and wound infections. So some of the underlying drivers that worsen these are delays in primary care access, rural distance and transportation barriers, home care, respite, supportive housing, and long-term care capacity gaps. As our population, frailty, cognitive impairment, functional decline is getting worse, polypharmacy and medication transition errors, and lack of rapid diagnostics outside of the hospital. So the CP program, eh, we're trying to be the right care in the right place. Our primary focus is early identification and rapid response treatment and scheduled follow-ups before 911 becomes the only door left to these patients. Um, this right here is just a brief history and purpose of community paramedicine. Uh, Paramedicine is, or community paramedicine is something that exists all across the world. Every province except for Quebec has some form of community paramedicine. It's very large in Australia, it's very large in Europe. Um, it's something fairly new. It's only been around in Ontario since around 2014. It came from EMS roots. It started off with, again, paramedics, rapid assessment and treatment. They started identifying high-risk patients through repeated 911 calls, frailty, chronic diseases. And what happened was the first community paramedicine program was actually a referral program where frontline 911 paramedics who were identifying these patients who could use additional services in the home were actually able to do direct referrals. They were called CREM referrals. They were able to do direct referrals to Ontario Health at home. So we were actually isolating, or we were actually identifying these patients frontline. Then we developed the CP model. So this was started doing scheduled home visits. We started doing clinics and monitoring and sending out referrals from a more um, uh, clinical standpoint, where the community paramedic can go in, do more vitals, and actually take their time to assess the whole picture surrounding the patient. As community paramedicine has developed and grown and evolved, particularly over COVID, we've seen a massive expansion in scope of practice. Uh, Community paramedicine programs started taking on medical directors. We've started taking on additional training. We've introduced point of care testing. POCUS, which is a point of care ultrasound, has just started and is uh, quite a useful tool and new. And some programs like us have developed virtual care, which is absolutely critical in rural settings such as ours. So again, the whole focus around community paramedicine, like I said earlier, is access and capacity. We're trying to create access for patients living in community, and we're trying to build in capacity to primary care providers. So care closer to home equals fewer avoidable ED visits. Um, Oops, sorry. So the training that community paramedics go through is quite extensive. It's People always assume a paramedic is a paramedic is a paramedic. That is far from the truth. Community paramedics do have a background and they come from the 911 emergency side, but they go through quite extensive training to reach the level of community paramedic. So the first thing they do is they take additional community paramedicine certification courses, and this covers everything from chronic disease management, home visits, pharmacology, advanced assessments, specialized therapeutics, care planning, etc. Once they're in the program, they go through additional palliative care training. They learn how to do proper PPS, ESAS. They learn about symptom support. caregiver coaching, goals, and awareness. All of the community paramedics in our program are then put through wound care and ostomy certification training. So this trains them in advanced wound care assessments, dressings, pressure injury prevention, infections, and surveillance. Recently, we've sent all of our community paramedics through POCUS certification training. So all of our community paramedics in Perry Sound District are certified for point of care ultrasound, specifically on lungs, subxiphoid cardiac, and bladder scans. All of our paramedicines, we do in-house training for phlebotomy and EPOC, specimen collection, and labs. And every year we do competency maintenance where we run CME and do simulations, chart reviews, case reviews. Every year we review our directives, update them. And again, we work with a medical director who is Caitlin Beatty, who is on today, a nurse practitioner, fantastic. Um, how the program operates, this is our operating model. A It starts with a referral or a trigger point. So we do not receive referrals from the general population. All of our referrals come from either primary care, hospital, home care, either right from the 911 paramedics, remote patient monitoring alerts. Once the patient is actually rostered with us and we have them in the program, we actually give them a magnet with the community paramedicine phone number on it. And it goes on their fridge, and family members, caregivers, patients themselves are instructed. They're trained to when you need us, so a low acuity episodic event, or there's something that's in our scope of practice that we can help with, they can initiate the call and they can call us. So some patients will be rostered with us and may not hear from us for several months, up to a year. We'll periodically give them a phone call, check in, update their charts, make sure everything's looking okay. But ultimately, we don't activate until we get a second referral from either allied health agencies or from the patient or the family themselves. Uh, Once the initial referral comes in, we do an in-home assessment, we do history, vital signs, physical exam, we develop a baseline, look for red flags. Subsequent visits, we're able to refer back to that to see if this patient is deviating from their baseline, if they're decompensating. Um, Diagnostics, we do point of care ultrasound, EPOC, ECGs, urinalysis. We run otoscopy digitally and wound imaging. We work closely with primary care providers and specialists. Uh, Ultimately, we follow orders. So we work under our medical director's license, and we do have directives in place, but we always consult with the patient's primary care provider or attempt to consult with the primary care provider when they're available. And we do follow up. Um, Ultimately, the model operates on a closed loop system: identify, assess, test, treat, consult, monitor, and then report back. Just quickly, I'll go through this really quick. Services delivered in community. We run clinics and prevention, routine medication administration, symptom relief for minor ailments. We monitor wounds, dressing, skin tears. We have pathways for antibiotics. We do chronic disease management, diagnostics, transitions from hospital and palliative. Um, We also do education in the home. We run this, it's called Go Medics Direct Health Ed Education for Patients, which is a standardized platform. So when our medics go in, we carry all of our documentation, our EMRs are all done digitally through a tablet. And the medics will actually set the tablet up, and it has modules for either diabetes, CHF, COPD, or wound care. And during our visits, while we're performing other tasks, other assessments that we were sent in to do, we'll actually run through health ed sets for the patient. So it's a focused assessment. Um, it allows the patient to do the teach back method. So we can actually ask questions, have the patient respond in their own language. It gives visual cues so we can actually show patients what we're trying to explain. And it's standardized, so every medic is explaining the same thing in the same way. Uh, Specimens, procedures, and point of care assessments. Uh, Community paramedics, we do a lot of specimen collection, oropharyngeal, nasopharyngeal swabs, wound cultures, sputum cultures, blood collection, urine collection. We carry now rapid antigen testing for screening for strep throat, influenza, RSV, etc. As far as procedures, we can do 12 lead, 15 lead ECGs. We do ankle brachial indexes with handheld Doppler. Again, digital otoscopy. We can do ear flushing, IV starts, catheter flushing. Along the bottom here, our blood work that we do is exception based. It's not routine and it's not meant to replace community labs. The provider role again is central. We require requisitions, and for us to go into the patient's home to do blood work, we really do require that the patient has no other options. They have to be homebound, and it's a fairly unique situation. And just this image here along the bottom shows just some of the point of care equipment that we use in the community paramedicine program. So on the far left, you'll see that that's a point of care spirometry. The next one over is actually point of care wound imaging, which actually will show bacterial loads. That's the digital otoscope that we use when we're looking in people's ears. So we can actually save the images, upload it to the chart, and share with primary care providers. And then there's an epoch blood analyzer, ultrasound, and a urinalysis machine. So this is the two devices that I really want to kind of focus on. I kind of skimmed through everything else really quickly because I really want to focus on point of care, ultrasound, and blood analysis. So the epoch blood analysis, it it's a device that allows us to make real-time decisions at the patient's bedside. Specifically when it comes to titrating certain medications like Lasix or certain antibiotics. Point of care ultrasound, again, it's we're focusing on lungs, subxiphoid cardiac, and bladder scans. Uh, what we're using it for is to basically reinforce what our assessments are already kind of pointing us down. So why should physicians and NPs care about this? Well, together, when we take point of care ultrasounds and blood analysis, it helps us determine whether the patient can be treated and monitored at home or are the needs does this person need to go in for further assessment and emergency or further imaging? It's about safety boundary. These tools are just adjuncts. They don't replace imagery. They don't replace laboratory medicine, physician assessments, or emergency transfers. It's just another tool that we can use in the field when making clinical decisions. So again, the goal is not more testing. The goal is decision capable care at the bedside. So point of care ultrasound at the bedside. What we're doing, like I said earlier, is it's not formal imaging. This isn't like going to the imaging department at the hospital. This is real-time clinical clarification. So when we're doing lung scans, our community paramedics are called in for a reason. Either the person believes they're having a COPD exacerbation, they've got a recent cough, or we're during our assessments, the paramedics are using a stethoscope and they're listening and they hear something in the lungs that are leading them to either suspect this is a fluid or this is like an infection. What the lung scans do with the ultrasound is we're actually now able to validate that. We can actually look and say, okay, does this look like consolidation for consistent with pneumonia or an infection, or is this more, pleural effusion? Is this now B lines, which would be more consistent with, a fluid issue such as in like CHF? Subxiphoid cardiac, again, we're not doing formal echocardiograms. These are We're looking to see cardiac activity. We're looking for pericardial effusions. Same with bladder scans. We're looking for bladder volume. We're looking for urinary retention, possible catheter obstructions. A lot of the times, by doing a bladder scan, we can avoid unnecessary catheterizations. for patients that aren't retaining. Again, when we're doing these point of care ultrasound assessments, they must be interpreted with a history vital exam. We're using other equipment like epoch, trends, and medical oversight. These aren't, we're not just doing it for the sake of doing a point of care ultrasound. Uh, if we look in closer here at lung point of care, um, we have clinical targets. We can actually see like focal consolidation, dynamic air bronchitis, bronchograms, pleural effusion, interstitial syndromes, OB lines. We can see absence of presence of lung sliding, A profile versus B profile patterns. The implications of this in the home setting is our medics can now uh, they can now communicate or patch through to either primary care or our medical oversight, and they now have data that supports their suspicions. Is this are we taking a pneumonia pathway in the home? Is this CHF versus COPD? Is there a need for antibiotics or diuresis? Does this person need to go to the ED for more imaging? Is this an urgent transfer? Or is this person's baseline? And do we just continue to assess? And again, you can see how what we're using is the Clarius HD3 PAL ultrasounds. So every one of our community paramedic trucks currently have one deployed. And it's a very simple device once you're trained on it. It's a Bluetooth connection, and again, it runs through the tablets that our paramedics use. So it's pretty neat. They can set it up on a tripod, and they have their image in front of them, and they can continue with their scans fairly hands-free. Subxiphoid cardiac and bladder point of care ultrasound. Two focused exams that can change the disposition and home care planning. So again, this is all very you know clinically relevant data that we can now relay to primary care providers and medical oversight in real time. So it allows us to do real-time decision making. You know, uh, you can visualize bedside data to support our medical directives, which is, compared to trying to describe something over the phone, now you can actually see it. The other device we use is the epoch blood analysis. So again, something that can be done at bedside. We're already in the home doing lab draws and blood draws, part of our specimen collection. So what this device does is it actually allows us, again, going through our medical directives, we can make real-time decision making in consult with primary care and physicians for analytes. We're able to check a patient's creatinine, potassium, sodium, uh, lactate, pH, glucose levels. It's a simple blood draw into a dry lithium heparin tube. Uh, it's less than zero point 0.1 cc, and when you run it through this machine, you've got 1 minute, and you get a complete workup of the labs. And it allows us to actually check a person's eGFR, so we can actually check for kidney function. Again, it's designed for clinical decisions in the home. Is diuretic safe in CHF? Choosing antibiotic selections, renal dosing, etc. Are we escalating based on the results that we're getting? Um, Medical directives are the backbone of the community paramedicine program. They define who's eligible, what is excluded, when to patch, and when to follow up. So these are the main categories we have for our medical directives. And again, I should say all of our medical directives are available publicly online through our website. They cover chronic disease management, so CHF and edema, COPD. It's broken down into mild, moderate, and antibiotic therapies. So we cover antibiotics for UTI, cellulitis, pneumonia, pharyngitis, and we also have antibiotics for COPD exacerbations. Uh, simple symptom relief medications for analgesia, headache, minor allergic reactions, nausea, vomiting, diarrhea. We have medical directives for all of our invasive point of care testing and specimen collection. We also have medical directives for our more invasive wound care procedures, such as suture staple removal. We use skin glue for re-approximating skin tears, category one, category two, IV access, otoscopy, ear irrigation, catheter flushing, point of care ultrasound, and spirometry. So these directives basically lay out the pathway that our community paramedics will follow, and every single one of these directives ask who is eligible, what is excluded, what data is required to perform these directives, who must be notified, and what follow-up is mandatory, and when do we escalate. This right here is just it's a simple example of one of our directives. So this is our pneumonia directive. I've just taken a couple just screenshots of our indications so you see how we determine if we're going to be running this directive. And so our indications would be for this pneumonia is like a pneumonia symptom, adventitious breath sounds. Then we would move on to, okay, we're going to do a point of care ultrasound looking for consolidation. And then we want to determine, is this patient medically stable using the CURB 65 scoring method? And so if the patient does qualify for this and they meet all the conditions for the treatment options, those there's I took another screenshot there for treatments. So there's red bars. Those are mandatory patch points. So we're patch notification. We are going to request the prescription. We're going to notify the primary care provider, or if we can't reach the primary care provider, what we'll do is we'll reach out to our medical director and have a quick conversation um, and proceed. Again, safety boundaries. Uh, we won't be proceeding with this if they don't meet the conditions or if the patient has any contraindications. Medical directives also, unlike the 911 medical directives that are basically last from the initial point of contact with the patient on the 911 side until the transfer of care in the emergency department, which can last anywhere from a few minutes to a few hours. The medical directives in community paramedicine can last days or even in some cases weeks. So there's follow-up. We have red flag education. We'll consider putting in remote patient monitoring if we feel that this patient requires close monitoring in the follow-up to the treatment. And we have guidelines as to when we do follow-up phone calls and the number of days when we have to do another home visit and reassessment. So again, it all comes down to safety model. How a safe home treatment is built. It's no one single tool that makes the care safe. It's the combination. So it's how we perform our assessments, our vitals, our exams, basically, and then that's why we won't perform any of these directives on a patient who's not already pre-rostered on the program with the community paramedicine program. We want to make sure they're pre-rostered so we know what their baseline is, so we know when there's a change. Using again the technology, point of care ultrasound gives the imaging just gives us a far clearer picture of what we're dealing with. EPOC blood analysis. Again, now we're actually able to look to see what their renal function is, what their electrolytes, their glucose, hemoglobin, etc. And again, the directives, these are again the framework, the backbone that keep everything standardized. They prevent medics from, freelancing and deviating from preset directives. And again, having a medical director that's available for consult. Just like on the 911 side, having a medical director that when you're on a 911 call and something's not quite going as it should, or you have questions, there's always the opportunity to patch for advice or there is a need to deviate from the medical directive. So having our medical director available for answering questions and follow through is very important. And again, community paramedics, we work 7 days a week, so there should be no gap in or very little gap in follow-up. We work as a team. Our notes are all shared, so it's not one individual. One paramedic may be doing the initial assessment. A second paramedic may be performing the intervention and initiating the directive. And then 2 days later, another community paramedic will be reading through the chart, have the task, and perform the follow-up. And again, remote patient monitoring is a valuable tool for close monitoring and tracking the patient's trajectory. Are they getting better or are they getting sicker? So what can remote patient monitoring track? It tracks SpO2, blood pressure, heart rate, weight, and glucose. So when do we use remote patient monitoring? We tend to use it after we've started a medical directive for either a CHF or a COPD exacerbation. And what we want to do is, or even like a pneumonia, lung infection, where we want to closely monitor what this person's vital signs are doing, and we can actually trend it. And again, it's good to keep records of these because it's we can actually with when primary care is involved, we can actually print off a report of the remote monitoring data and send that off along with our initial assessments, the assessments at the time of the treatment plan, and then the follow-up. So again, it's a complete provider loop. You start with the directive, remote patient monitoring setup, trend review, follow-up, and then report back. This right here is just an example of a COPD pathway that a community paramedic might take. Again, it's early treatment plus monitoring. Uh, Point of care, one of the hardest things in the 911 using a stethoscope is, and I've been in the situation many times on the ambulance where you're looking at a patient's history. They have a history of COPD, they have a history of CHF, frequent pneumonia, and in the 911 side, you have to treat either COPD or CHF. And it's very, very difficult in the 911 setting to determine which way to go, which path. So now with having community paramedicine, if we can intervene early, um, having a point of care ultrasound to see are we dealing with fluid or are we dealing with infection is absolutely critical. So known COPD, this is again for a COPD pathway, clinical trigger. A known COPD with worsening baseline symptoms, they call our non-emergency line and they say, I'm not feeling well. Our admin schedules an appointment. Rapid response is generally within a few hours to a day. We send a community paramedicine out who then will do auscultation. If auscultation is confirms adventitious sounds, community paramedic will then utilize the point of care ultrasound, looking for either B lines, focal consolidation, pleural effusion. If that's confirmed, the community paramedic will then move on to the EPOC, where we'll now take a blood sample, run it through, check for metabolites, kidney function. And then if everything checks out, we will then patch through to our medical oversight and we'll initiate the directive treatment. And in this case, it would be salbutamol, Atrovent, prednisone, might be titrating some oxygen, and we would start the person into an antibiotic therapy. Uh, Follow-up would probably entail some 1 week of remote patient monitoring, phone call from one of the paramedics within 24 hours, a home revisit when if symptoms persist, and because we have the direct health ed set while we're performing these interventions, the community paramedic would probably be doing some education with the patient. And there's always the escalation threshold. So if the patient has any red flags, we will do a warm handoff to 911. We'll call them in, and generally our community paramedics will give a report to either the medics transporting the patient in, or they will actually go with the patient to the emerge to do a handoff. Something very similar for CHF edema pathway when it comes to diuresis decisions and you require data. Clinical trigger, no on CHF with increasing peripheral or pulmonary edema, dyspnea, weight change, volume overload symptoms. Again, community paramedics would go in and if auscultation warrants it, would start into the point of care ultrasound looking for B lines or effusions, possibly a subxiphoid view for high risk findings. Uh, they would also then move into EPOC. They would draw blood, look for kidney function, sodium, potassium, which is again built into our Lasix directive. If the patient meets all the conditions, it would be a patch to our medical oversight, and patient would be their Lasix would potentially be titrated. And again, follow up phone calls within 24 hours, revisit the patient within 2 to 3 days, repeating vitals. Remote patient monitoring again could be put in with remote patient monitoring weight scale, so we can not only monitor blood pressure, oxygen saturation, but we can also monitor weight gain. And this now moves on to the paramedic supported virtual care hybrid model. And this is my favorite part because this is kind of what ties the whole thing together. Um, with this right here, we can now literally bring the decision maker, the primary care provider, the medical oversight, we can bring them directly into the home virtually with us. So now the decision maker has the ability to use point of care testing, vital signs, and all of our assessments without physically being in the home with us. So it all starts again before the visit. Reason baseline equipment. Why are we going in? Why are we setting up virtual equipment? At the bedside, we can do vitals, medication review, focused exam, look for red flags. And then we will actually have primary care providers or medical oversight or specialists. We do this with diabetes education. They can actually patch in for live collaboration. They provider can direct exams, review our findings. They can order diagnostics, so they can order EPOC, ECGs, urine swabs, point of care ultrasound, and or imaging. And again, plan and loop, prescription, referral. Are we going to put remote patient monitoring and reassess? So this is the kind of the flow for how our virtual care works. And again, it's critical when we work in such remote areas where we have a lot of homebound patients, as I described earlier, like reasons why a person can't just jump in their car and go to the walk-in clinic or to see their primary care provider, or even go to emergency, the ED. Transportation and barriers are very, very challenging. There's a lot of homebound patients, and without options like virtual care, uh, these patients just aren't being seen by their primary care provider. Um, the virtual visits are all pre-scheduled with the primary care provider or our medical oversight. The paramedic visits the home in advance before the appointment, does whatever predetermined assessments and screenings need to be done. They record vitals and if needed, blood work, urine, ECG. Community paramedic, we bring all of our own secure equipment with us. They set up a tablet on a tripod. We have speakers, microphones. It's a very quick setup. Uh, we set up the link with the physician or nurse practitioner. The provider and paramedic collaborate in real time to assess, diagnose, and adjust treatment plans. And again, using the new portable blood analysis, allow immediate lab results. So we're getting real time decision making. Uh, I was sitting in on a national community of practice for virtual care, and one of the largest reasons for failure of virtual care in community is we're expecting the patients to be able to be somewhat tech savvy. They have to be able to have their own devices. They have to be able to connect. And most virtual appointments in community fail for that reason. The seniors either don't have the equipment, they don't have the technical know-how to set it up, to actually run it. And the providers end up getting frustrated, the patient gets frustrated. So having a hands-on paramedic in the home that can take care of all the technical stuff, plus have the ability to reinforce what the primary care providers are trying to explain to the patient and to be able to do the assessments is absolutely critical. So who can community paramedicine connect to from the bedside? Primary care MPs, diabetic educators, respiratory therapists, specialists, medical directors, palliative care. For maximum results, community paramedics, we're looking for homebound patients. These are just some examples of like good referrals, bad referrals, when to use community paramedics. So I'm just going to skip through these really quickly because I want to get into our case studies before I run out of time. So here's some of our case studies. So here's a patient, a 100-year-old female patient with mobility and transportation barriers, 2 weeks of worsening cough, congestion, weakness, crackles. She declined an ED transfer when she was seen by a community paramedic. Community paramedic performed a lung auscultation on point of care ultrasound, noted consolidation. An EPOC blood analysis was done to check renal function. Our medical director was consulted. Antibiotics were administered or begun. Medication delivery within 24 hours, there was a phone call, 48-hour revisit, home visit with a repeat POCUS. Again, something very simple. Outcome, symptoms improved, repeat imaging supported the improvement, no ED visit or admission, and independence was preserved. So this is a good example of point of care ultrasound, EPOC, and it made the home decision capable. Another situation was a palliative CHF patient with fluid overload bridging. So it's a homebound patient after discharge had medication changes and delayed palliative service connection. Again, we always see lots of delays when we're doing handoffs in community. The patient developed edema, dyspnea, pain, and it caused caregiver distress. They called the community paramedicine. We moved in. We completed vitals, ECG. We did a lung point of care. We did an EPOC checking renal and electrolytes. We performed a PPS, ESAS palliative, PPS and an ESAS assessment. We connected directly with a palliative care physician virtually who did a medication review. We made diuretic adjustments and caregiver coaching. Outcome, edema and comfort improved, caregiver confidence improved. The patient was able to stay at home where they wanted to be, and everything worked out. Another one was a COPD exacerbation. We had a 90-year-old female patient living alone with COPD, mobility barriers, no transportation, and barriers to primary care access, presented with worsening cough and green sputum. She called Community Paramedicine. Community Paramedicine came in, did their assessment. We used a digital stethoscope, recorded the lung sounds, gave the findings to the primary care provider. We initiated the COPD directive, administered salbutamol, Atrovent, prednisone, doxycycline under guidance, prescription support from our medical director. There was a next day call, a home reassessment, and follow-up lung point of care ultrasound. The patient's symptoms improved, vitals stabilized, and COPD exacerbation resolved without ED visit or admission. Another one is a bedbound 74-year-old female patient living in a remote community with diabetes, mobility limitations, and she ended up with worsening leg blister, redness, and signs of infection. This all happened shortly before Christmas time, so services were scarce. CP intervention, we did an in-home assessment. We started the patient on an antibiotic with our nurse practitioner oversight. Advanced wound care was referred in. There was a delay, so community paramedicine had to continue coming in to assess the wound. It was then noted that there was a pressure ulcer. An NSWAC and occupational therapy was brought in, and in coordination with the community paramedics, we worked on teach back education for how to manage the wound at home. Eventually, the NSWAC was able to come in and begin treating the wound. The OT came in, adjusted the patient's, put an air topper on the mattress to prevent further skin breakdown and pressure ulcers. End result was the cellulitis resolved and stage 3 pressure ulcer healed. Patient remained in her home community and avoided hospitalization. And I think this is my last one. We had a 79-year-old male patient with atrial fibrillation, new CHF diagnosis, and was discharged from the ICU with medication changes. However, he continued his discontinued medication with his new medication, causing bradycardia and hypotension. A family member called Community Paramedicine. We moved in, completed a post-discharge assessment. We did a medication reconciliation. We removed the discontinued medication from his docket, provided CHF education. We repeated vitals. We did a follow-up blood work, and he didn't have his vaccinations, so we did that while we were there because, hey, why not? Within 48 hours, the patient's heart rate and blood pressure returned to baseline. His symptoms improved, and no ED visit or readmission was required. Some quick statistics on the Community Paramedicine program. This is from our 2025 year. In 2025, we had 225 low acuity episodic requests from service from patients or allied agencies. So these are patients that were already on program with us and receiving services, and we call these high intensity because we need to get to them within a very short time frame. Out of those 525, 483 of them were able to divert 911. Altogether, we did 268 point of care tests last year. We performed 689 delegated acts. That also includes our vaccination clinics that we run. We did 183 virtual hybrid visits, again, connecting with homebound patients with specialists or primary care providers, diabetes education, respiratory therapy. Altogether, our team did 3,959 home visits and clinic visits last year. On average, we're able to see a patient when we get a new referral. We're able to see that patient 64% of the time within 48 hours. 16% of the time, we're able to see them in 72 hours. 14% of the time, we're able to see them between 3 and 5 days. And 6% of the time, it's 1 to 2 weeks. And again, a lot of the times, those 3 to 5 days is usually the patient's availability, and 1 to 2 weeks is usually the patient still in hospital when we onboard them. So in closing, again, it's about sending the appropriate resource to the cat in the tree scenario. Save the fire truck for the structure fire. Save the ambulance for the emergencies. There's no point in sending an ambulance to a person that has an infected toe just to have them brought to the hospital. We need to make sure that we're very cognizant about keeping emergency vehicles where they need to be so they are response available. So the question changes from does this patient have to go in to what is the safest pathway for this patient? That's all I have. So I think I've still got some time for questions if there is any. But please open for feedback. I think Kathy, you said you're going to be sending out a survey.
Yes, I'll be sending out a survey link later today to those who participated. So thank you for mentioning that. And we'll open it up for questions if anyone wants to unmute and
I
ask.
apologize. I apologize for rushing through some of that really quickly, but I was trying to be cognizant of time.
Dr. Witt has a question, Todd.
Yeah.
Hi, Tom. Great presentation. I just want to say that sounds like an amazing program and amazing service you guys offer for the community. Um, I'm wondering about the uptake in the community. Is it generally like all nurse practitioners and all family physicians in the community, or do they have each have patients enrolled in this program? And if not, have you done some awareness kind of campaigning about it?
No, actually, thanks for bringing that up, Dr. Witt. We are definitely again, we never really, when we first started on this program, we never had medical oversight. We never had medical directives. We were just kind of enrolling everybody from everywhere and hoping to interact with physicians. But as our medical directives and our scope of practice has expanded, we definitely need to be doing more awareness. We have done a few information sessions, but I think it's such a vast program and it's changing so quickly. I think it's very, very hard to really explain what we're capable of doing and really make that differential that we are not home care. We're really that bridge between ED, primary care, and home care. We have different levels of engagement with different primary care providers. Like I say, some of our primary care providers from the family health teams on the east side of the district, they use us for all of their homebound patients and are huge advocates, and they really maximize what our capabilities are. And we're starting to see a lot of that now with some of our primary care providers on the west side. But there's definitely it's not equal. There's definitely some providers use us more than others. And we're actually going to be launching a campaign to actually show, okay, this is what we do, but we're actually going to be asking that the primary care providers will only go in to see their patients if they fully understand what we're doing. And we're going to start asking for them, can you please sign off saying that these are our directives, this is what we're going to do. And if you're not okay with that, that's fine. But we can't be going in to assess patients if we don't have we're not able to do the proper follow through and to actually initiate these directives. Because we've had situations where we've gone in and we've gotten the testing done, we've done the ultrasound, we've used our time, and then primary care doesn't want us to initiate the directive. And that's fine. That's not a problem. But we can't be going in to see all these patients if we don't have the physician on board. Sorry, I hope that answered your question.
No, that was great. I wonder, yeah, I wonder if maybe the clinics would be open to say like a brief noon teaching round similar to this, but directed at their clinics, maybe even starting through Dr. Neary and Dr. Anderson through the OHT, through your involvement with the OHT, just as since they're the leads of the clinic. Because I do think if they were educated on the service you provide, I imagine your uptake would increase even more. And I can see their hesitancy in signing off on medical directives if they don't really understand the program.
Yeah, absolutely. And I think it goes back to like you know, people don't I don't think they like you see a paramedic is a paramedic is a paramedic, but I think this right here is a very specialized team of paramedics that are this is their primary focus. They've got the additional training, like they're certified in ultrasound. These are specifically what our paramedics are looking for. They're very, very different from the 911 paramedics. And like I say, the physicians that we work closely with, we've had fantastic results. And our medical director, Caitlin Beatty, we've been doing this for years now, and we've had absolutely fantastic, specifically with unattached patients. It's we've seen absolutely incredible results. So anyway, yeah, no, I think meeting with more primary care providers and again, unfortunately, we're a small team too. We cover over 9,000 square kilometers, and there's six of us working 7 days a week. So, unfortunately, our capacity is also very, very limited to how many people we can work with and how many interventions we can perform.
Go ahead, Becky.
I'm just wondering, how does your service collaborate or coordinate with home care services?
Yeah, so we do. So is this are you talking like Ontario Health at Home?
Yes.
Yeah, so we actually we meet monthly to discuss program changes and enhancements. Uh, we get calls all the time, so it's refer in, refer out, and we actually collaborate on care plans. So our program tends to be very quick at responding and doing, again, laboratories and point of care assessments. So Ontario Health at Home might get a request and they have a delay in nursing, so they'll call us and we'll go in very quickly. We'll basically do a triage on the patient, and If it's more chronic long term, we'll say, okay, we'll bridge the gap from day one to day two. And then once nursing is able to get established, a care plan is developed, they'll move in. So we support Ontario Health at Home care plans, and we'll refer out to them when we see something that maybe doesn't fit quite our criteria, or we've gone in and we've started into some wound care. We'll do in like short-term wound care, but we don't do long-term wound care. So we might start the wound care and then we'll pass it off to Ontario Health at Home. So it's very much a back and forth where we'll get calls from care coordinators and referrals in all the time. And a lot of it is collaboration on these care plans. And again, we work very closely with a lot of the nurses that are actually frontline out in the field. Rapid response nursing is just absolutely fantastic, and when very different skill set. And when you get a rapid response nurse and a community paramedic working in tandem, it's pretty awesome how we can move things along. Sorry, I hope that answered your question.
So in the comments, Tom, there's from Dr. Smith, thanks for the presentation, Tom. Your team is doing great work. And Sherry also mentioned great job. So thank
Awesome.
you.
Appreciate that. Thanks, guys.
Any last minute burning questions before we wrap it up? I'm not seeing anything, Tom. So thank you so much for coming and sharing what your team is working on and all the advances in the program. I've been fortunate to work with you from almost day one. So this is
Mhm.
fantastic work that you've accomplished since the program's come into creation. So
I appreciate that, Kathy, but honestly, it's not me. It's a team effort, and I do have to give a shout out to the awesome team we have in community paramedicine, and a shout out to our amazing medical director, Caitlin Beatty. Like honestly, without the team and without Caitlin, uh, none of this would happen. So
okay. And just to let everyone know, our next set of rounds will be June 25th, and it will be Dr. Wolf and Dr. McGregor, and it will actually be an in-person session in the celebration room that day at noon. Please come join us, have a bite to eat, and listen to them speak. They're both neurosurgeons out of Sudbury, so looking forward to that talk as well. Thank you, everyone.
Thanks, Kathy. Thanks, Tom. Thanks, Caitlin.
Thanks, Tom. That was great.
awesome. Thanks, Billy.